part of my problem is the thinking that primary care necessarily means you having less qualified care. If you look at it that way, you get it's wrong. They've just put up a system that is they're doing poor medicine for poor people, but they are collecting a lot of money.
SHIF.
It's like putting the cart before the horse.
Exactly.
And the question comes is, why are you so much interested in the money and not the service? Because you're taking our money, fine, but you're not yet ready to give us this service that you're saying you will give us. And that's the biggest question that personally I've had from a policy analysis perspective.
Have you registered?
So surprised. I registered back in April when they were doing the first testing.
Yes.
So I did the first proxy means testing.
Yes.
So I'm waiting for the outcome of the court cases.
Why are you waiting for the outcome of the court cases?
Because I have my reservations in regards to how the entire rollout and how the whole design is.
But you or one of your family member might get sick today.
I'll cross that bridge when I get there.
An estimated 1.1 million Kenyans fall into poverty each year. And that's because of healthcare costs. Would SHA, SHIF, UHC change that, or is there more? Or perhaps, what's the difference between a pharmacy with a blue cross and a green cross? What about cancer and the rising incidence amongst the youth? Is it just lifestyle changes, or is there more?
Women's health, men's health, your children's health, the economy, this and more awaits you on season 2 of Kenya's favorite health podcast.
My name is Dr. Diana Wangari Gitau, and welcome to season 2 of the One Health Lens podcast.
Welcome to the One Health Lens podcast, where we have conversations around health and related topics, making them simple and easy for you to understand. I'm your host, Dr. Diana Wangari Gitau.
And I am Dr. Simon Moshara Kigondu.
The energy is there, yeah? Today we're talking about, SHIF. It's been 1 month since is it the launch? I don't know, but since the official D-Day. 28 days, right? What has been happening in this past 3 weeks? We have in studio with us 2 important guests, as always, who will introduce themselves and we'll get going. Doc?
So Okaka, a concerned Kenyan and a medic in this country.
Yes.
Dr. Chibanzi Mwachonda. I'm a clinical doctor. I practice clinically.
Unlike these others.
No. He does. Okaka here. Okaka veered off. And I'm also a health and labor policy expert here.
Yes. Okay. Good to have you again, guys. So let's start off with, have you registered for SHA? Let's start with Okaka. Have you registered?
So surprised. I registered back in April when they were doing the first testing.
Yes.
So I did the first proxy means testing.
Yes.
The only thing I haven't done is put in my biometrics. So I'm probably different from most people.
And that includes your entire family is registered?
No.
It's just
the rest of the family do not want to register. Sadly.
Rebel.
Okay. Doc, have you registered?
No, I've not yet registered. And one is, there was a forceful transfer, I'd say. I'll use the word forceful, from NHIF to SHA. But I know there's a court case going on in regards to the whole transition. So I'm waiting for the outcome of the court cases.
Why are you waiting for the outcome of the court cases?
Because I have my reservations in regards to how the entire rollout and how the whole design is.
But you or one of your family member might get sick today.
I'll cross that bridge when I get there.
Okay. You've hinted that there was seemingly a forceful approach to the transition, right? And most people would say that one day they woke up and got a message that said, you have been migrated, right? So I'll start again with you, Okaka. Oh, wait, Kigondu, have you registered?
I'm interested in Okaka's. How much did they say from your means testing you should pay? Did they give you a figure?
No, they didn't.
Oh.
I think at that point they were not giving figures, but
okay.
I was just looking through the questions.
Okay.
You know, the type of house you live in,
Yes.
what it's, the material that it's made of, whether you have a car, whether you have a radio. They sounded more like census style questions. Yeah.
Okay. I mean, maybe let's follow that thread. So you registered, right? What has happened between then? So you registered in April. Between April and now, what has happened? You have gotten, I'm assuming, some updates from SHA?
No, nothing other than what I see say on news.
Yes.
So nothing else, and probably that's what is confusing. So I don't have a SHA number, or like no details sent to me say, hey, this is now your SHA number.
That's the problem.
These are your SHA details. Unless maybe if I log in and see now whether that.
Where do you
that is
even
there.
log in?
I think the website is available publicly, sha.go.ke. Yes, and so the information. What I'm saying is, this information is not as public as should be, and this is not the first initiative government is rolling out nationally. I mean, the polio vaccine drive has had more
communication than this.
Yeah, so
okay, so between then and now, and did you get the message around you've been migrated? But no, you didn't get
I
that
did not
message
get
at
that.
all.
That's
You
interesting.
didn't.
Yeah.
Mwachonda, did you get the message that you've been migrated, your NHIF has been migrated to SHA?
Yeah, I did receive that message, and at that point, I think when I received the message, I was like, okay, fine, you've gone ahead and registered me, so why should I go and register myself?
Have
And
you been
that's what that action communicated to me.
Okay,
Yeah, that we've moved you from NHIF to SHA, and we've moved you because we're going to deduct your money from your salary. So it's like, okay, you've gone ahead to do that.
Yes.
Then I went through just to understand the challenges people are going through with the registration. And that has been a big problem, actually, because most people are saying the star 147. I have very close family members who tried to register and it failed several times over an entire week. Trying the star 147, not working. There are those who've gone in, keyed in their details, still no response. The system is down. So I was like, well, there's an issue with the transition. There's a court case. So even if I try now, from the experience, people are like, why should I?
You've seen from others, it's not working.
It's not working, yeah. So
And
let
you-
it work, then maybe we can discuss
Okay,
that.
fair, but you've also made the assumption that given that you've gotten this SMS, you have been registered, you've been migrated, they've notified you that you've been migrated.
Yeah,
so
yeah.
there's that assumption, right?
Yeah.
So my question would be, have you been to a facility ever since to then try and tell them, you know what, I am, or give them given your ID number? Have you tried that?
Yes,
and
I
seen?
did. This is 2 weeks ago. I think it was on a Monday or Tuesday morning. I walked into a facility and I told them, I was first told we can only claim through SHA, because I went in like NHIF and I'm told it's still active. So they told me, fine, just give us your ID number. So keyed in my ID number. This is a facility system, the SHA system.
So
in a
you
facility.
were at a hospital?
Yeah, I was
at
in a
the
hospital
reception,
actually,
yeah. Okay.
at the reception, yes. So they keyed in the ID and then they turned to the computer and told me, you do not exist in SHA. I told them, how comes?
Yet you were
And I was
migrated.
migrated from NHIF. Told me, no, you don't exist. And I asked them, what about my contributions? And they're like, no, we can assess. Because I think at that point they already opened up the two systems parallel, because initially they switched off the NHIF system completely. So because it was open on the NHIF end and now there's a SHA system running concurrently, they checked and told me, no, whatever you contributed, whatever your benefits are in NHIF are still active here in this system. But now we cannot offer you service until
You're on SHA.
You're on SHA. That's what happened.
So is it, and just to get it clear, so NHIF in itself, the system is still active, and the contributions that you're making is visible within the NHIF
You had
system.
made before.
You had made
Yeah,
before.
yeah.
they're visible on the NHIF system,
Yeah,
right?
yeah,
So
yeah.
hospitals have visibility of the NHIF system,
yeah,
right?
yeah.
But because the claiming of, the service they'll offer you, the SHA system is where you need to be. And that's where there's the insistence of you must be registered on SHA.
In fact, I did it just to understand this entire thing. And what they did is they gave me the claim, the SHA claim form, and told me you have to fill this form. But you see, we can only claim as a facility based on your SHA registration number. So there's on
As
the
an
form,
individual.
as an individual, on the form, there's a SHA number that they'll use that SHA number to now claim for your treatment.
You don't have a SHA numbers yet,
I don't
and you have
know it.
registered.
If it's
You
there,
don't know
maybe
it. If it's there, you
maybe I
don't know.
need to log in and see if it's there, but I don't know it. It's not been sent to me anyway.
So let me put it in context.
Yeah.
My mother, and this, I think when I wrote an article on the good, the bad, and the ugly of SHA. These were the issues that I actually envisaged. I pay for my parents. Previously, NHIF, I pay.
6,000 a month.
And they go to a specific hospital allocated to them. So, and the previous, so when my mother got sick this weekend and she went to the hospital, two problems arose. One, this SHA, as Mwachonda is saying, tried to register and they were unable. You see, because they were in NHIF, they had gotten a message. And secondly, they were told that now this hospital, where they used to go for their outpatient, no longer sees outpatient. So it's a level 4, as in they used to go for, the outpatient. It's a level 4. So even they can't, even if they registered, now SHA,
They have to go down.
They'll
they have to go. And that's where, by the way, she has been seen all their life because it's next to the house. It's convenient to my place. So that those were, I think, there are some of the questions that we raised. And finally, I had to pay cash for the services she got, an X-ray and all. You see, so. And then at the end of this month, they are going to deduct SHA from me. And I still have to pay for my mother. So some of these issues are what we were really talking about.
And I think that's where the labor component of this entire policy comes in. It was never thought of from a labor perspective. It was thought of from a health perspective. But the minute you go into income tax to fund a project or a policy, you have gone into the labor side. And the labor side is that I had a chat with one of the proponents of this system, and I was telling him, have you seen the feedback from the public? Someone had put up on X that they're being deducted 41,000. He was like, he's being paid 1.5 million. That's fine. I told him, no, that's where you miss the point. This is labor in the sense that this income, if you look at it at 1.5, might look too much. But the country we live in is a low-income country. So this one person could be supporting 20 other people in their family. And that's the context that Kigondu is saying. So Kigondu is saying that I'll be deducted a lot of money, but when it comes to my dependents, I'm still the one who contributes. So I have to pay for them the contributions. So you're not paying for one person, you're paying for. And then the other angle is you're now reducing the income of people. Because, it's not just SHA. We have the housing levy. If you do the percentage, it's almost 10 to 12% of incomes people have lost in the last 1 year with no increase in payment. There's a cost of living. It's high. So essentially, we are putting salaried Kenyans in a corner. You see, and that's where the labor component was never thought of. And that's why you see the unions came out equally saying, you cannot just stop our comprehensive cover and now say we'll contribute and then get benefits just like anyone else. You see,
even before you even go to labor, because there's two elements, because you must know what you're getting, right? So it sounds like a lot of people are not even aware of what services they're going to receive. But something Kigondu has mentioned, that there was now the tier system. The fact that I used to walk into this hospital, I didn't know whether it was level 4, 3, whatever. It never mattered, right? most people would just go to the facility. He's just told us his parents can no longer go to the facility. They've been going their entire
That is
lives
close to the house.
because now it's a level 4. You must start to lower down. Do people even know what that is?
No, they don't. And it gets a bit more murky because the PHC Act asks facilities to come together and form
A
primary
consortium,
care
networks, PCN.
So this level 4 you're speaking to is supposed to
Go and talk to
Yes, to get a
neighboring
network.
facility.
public or private, and these PCNs are what you ideally should be registered to.
And just for context, PCN is a primary care network. And elaborate what that would mean. If they were to go out and form this network, what does that mean?
So that means then Kenya is supposed to divide itself into whatever number, say 1,000, let's just use 1,000, 1,000 primary care networks. So when you register onto SHA, you should pick a primary care network. So previously you were picking
A
A
facility.
facility, yeah.
right? Now you should pick a primary care network.
Is it?
Yes. Which are not defined right now. So you should pick a primary care network that is closest to you. And that's the first place you should receive your care. Any of the facilities within your primary, any of the level 2 or 3 facilities within your primary care network. And if then they are unable to manage that, then they send you to a level 4, so to the level 4 in your primary care network.
So
And at the registration, at least I tried to register one, then I stopped. They are pushing you to the some facility. It's sort of in relation to where you live, you know.
Yes.
So if you start saying, "Oh, you live in Kangemi," so they give you a
List of
a list of
facilities
facilities in Kangemi.
Kangemi, yes.
But I mean, I don't know whether
You
that's
don't know the
really
facility.
feasible.
And
I mean, that's wrong.
yeah.
I think for me, in addition to what has just been said, is this. So having a primary care network, I think it was trying to mirror the NHS. Because the NHS in the UK has facilities according, it's a tiered system, but then you know which facilities within, and you can actually call if it's an outpatient visit. You call, you explain, and tell you, fine, we can book you this time tomorrow. Our system is not yet there in terms of even geographically how our facilities are. In terms of even the organization, in terms of the public service facility, public health facilities and the private health facilities. I mean, you walk around or just take a tour
Yes.
of Nairobi and you'll see very many private facilities in very stingy places. You see, that's the first thing. Second thing is the Kenya Health Facilities Census Report by the Ministry of Health, released in December 2023.
Yes.
And for me, because this is an ecosystem being built, so you have a digital angle of it, you have the insurance, which is a financing angle of it, then there's a service delivery angle of it. And the service delivery is in the facilities that we want to offer services to Kenyans. Now, in the service delivery, the facilities, what is the status of the healthcare facilities in the country? And this was a very objective assessment done, and it's not us who are talking. It's still a government document that is available on a government ministry website, and you'll read it and look at it in terms of outpatient services. They try to look at 16 outpatient services, basic outpatient services, maternal child health, infectious diseases, non-communicable diseases, hypertension, diabetes. I mean, out of 12,000 plus facilities, only 7% can readily offer these services. Only 2% can offer the full range of the 16 outpatient services. What does that tell you if you're a policy maker? It tells you we need to improve this first. So the problem here is it's like putting the cart before the horse.
Exactly.
And the question comes is, why are you so much interested in the money and not the service? Because you're taking our money, fine, but you're not yet ready to give us this service that you're saying you will give us. And that's the biggest question that personally I've had from a policy analysis perspective.
And also and for me, health care in Kenya has come a long way, and we have our way of doing health. For someone to purport and come and claim you have a new system, primary healthcare network. You know, they tried that. By the way, the Cubans who came here, they initially told us they'll treat malaria, then they put them in hospitals. So you're trying to adopt a system that is not yours, you see. And again, I go to my mother. The model that they have given me has cost me money first, because now I'm paying out of pocket.
Yeah.
Secondly, there is no service she's getting. Okay, she will get, but I will pay. And secondly, even if we wanted to go the primary care network way, that hospital, now, if she's to choose a primary care network, she'll actually go further from the hospital, which is actually has been giving her care for the last 10, 15 years, to go somewhere to look for that primary network, yet it has no service. I am sure there are no, here, this particular one where she sees by a doctor, and she's given basic kind of medication. So part of my problem is the thinking that primary care necessarily means you having less qualified care.
Yeah.
If you look at it that way, you get it's wrong. They've just put up a system that is they're doing poor medicine for poor people, but they are collecting a lot of money.
And it's okay if they want, if they dare to overhaul the system. That's still okay. But what's the hurry? We enacted these 4 laws in November last year. This is now less than 11 months, and we already
Deducting
deduct and enact everything in totality without question. When what we've seen out there, the example we were discussing with Mwachonda in South Africa, right?
Yeah.
They enacted a law in May 2024.
Yes.
The National Health Insurance Act. But they've given themselves up to 2028. So what's the hurry?
I mean, even before we go to that element, there are still some basic questions most people have. Because you're right, service delivery is key. So did hospitals, and even if we call them as providers, so that whether you're a hospital, you're a center, was there, in the same way there was some effort around public participation, was there forums of engagement for now these providers, right? The people who are offering the service, were there such forums?
So I attended a number of forums organized by the ministry.
From a provider perspective, not policy.
Yes, providers. There were show and tell. There were not discussions. There were, this is the benefit package we are giving. We are giving this for cancers. This is how we'll structure the outpatient service. So it was, hey, this is what we have. This is how we plan to band the contracts. It wasn't at the point of, hey, we are designing this, let's discuss what could work. It was, hey, we have designed this.
Take it.
We are bringing it. We are just letting you guys know what will happen. Then be ready.
So, were there questions raised at that point in time? So questions were raised, right?
Very many.
None of it was incorporated.
Very little, if any, nothing
substantial,
huge. Nothing huge
to prevent this chaos at this point.
Nothing huge was picked. And I'm trying to think back. No, nothing huge was taken.
So I think that the point I'd like to make out of this is, from a provider's perspective, the SHA system came into effect on 1st of October. 1st of October was not a statutory date, by the way. So you ask yourself, with all this, why was the hurry? This date was not determined by law. It was just a determined date because we feel we need to start.
People sat down and said, we'll start first.
Start 1st of October.
Exactly.
Now, what happened days before 1st of October? Experiences that I saw in a facility I was in over the weekend, and I was seeing patients, and I saw a very long queue, and I asked, what's this queue about? I mean, all these patients, they are inpatients. I was told, no, they're being discharged from the SHIF system because come the 1st of October, we will not be able to claim.
So you're admitted in a facility, you're in a hospital, you've been told you have to be discharged so that then we register you to SHA.
Yes.
So at that point, that was on the 28th, 29th, because 30th was on a Monday, 1st was on a Tuesday. That weekend of Saturday and Sunday, I know, and I saw it myself, patients who are being discharged. Not that they're going home, they're being discharged from the NHIF system, because the hospital is saying, where we are, these patients have been with us. And you know, in psychiatry, patients stay in hospital for quite some time. So what we are scared of as a facility is that we will lose this money.
We won't
because
get
once the system is shut off on the first,
Can't claim.
how do we claim?
And why are they scared? Maybe that's what you should explain.
And that's the point. The question you're asking with regards to provider engagement and provider
Yes.
information. Like, we're going to start on the first. So what played out after that? What played out is exactly what we saw. That private facilities refused to onboard on SHA and said, we'll just pay you'll pay via cash, because one, we don't know how we're going to claim, who we are going to claim to. There's no system in place for us to. Even claim forms at that point were not. Even contracts had not been done. They're not been signed.
Yep.
Yes.
Contracts were signed after 1st of October. I think the weekend after, around 8th, 9th. So you see, decide on a date and then chaos come the day.
This is not the first time systems have changed.
Correct.
by the way.
Absolutely, absolutely,
And I
absolutely.
think NHIF had switched their claim system.
And I think we're going to continue that conversation in the next
Yeah.
in the next discussion.